Excellent. So we'll make a start. So the whole point of this evening is that we're going to talk you through the value of some of the clinical services. If I can actually get the slides to move. Oh, here we go. So we're going to talk about these 4 key services in terms of their value to you as a contractor. We'll talk a little bit about how you can see the patient as a whole rather than just a service, and therefore maximise the value of the patient when they're in your pharmacy. And I think we've taken that last little bit off the slides now. We decided not to talk about the smoking cessation of the service after all. We just forgot to remove that bullet point. So hopefully you're all people who are here who are providing services, but we do get asked quite a lot of times, why do we need to provide services? Why can't we just continue to make our income out of dispensing? Because dispensing is my core business. I don't have time to do the services. I don't have the staff, and I don't actually see the value because I don't see a lot of money coming in from clinical services. However, as I'm sure you all know, the direction of travel is very much away from dispensing towards clinical services, and therefore that's why it's important, if you haven't already started, to start to think about how you can start to introduce those to your services, and also for the benefit of your patients. So I thought we'd start with essential services and DMS. So hopefully, because it's a mandatory service for you all to provide, you will know everything that's on this slide. So there was a setup fee of £400. DMS composes of 3 stages, which when you do all 3 stages is a value of £35 to you as the contractor. If you're in any doubt, it is a mandatory service, and therefore if you receive a referral from a trust, whether it be one in West Yorkshire or anywhere else in England, then you are required to do something with that referral, even if it's passing it on to somebody else because it's more appropriate. So, for example, elderly lady's been discharged from hospital and is going to go and live with her daughter for a while, but you're her normal community pharmacy. If you get the referral, but then it turns out after she's been discharged that she's no longer living in West Yorkshire, or your pharmacy is no longer accessible for her, then you can pass that referral on to a different pharmacy via Farm Outcomes. We're experiencing the fact that a few people didn't know that, and they're just rejecting those referrals rather than passing them on. So I thought it would be good for you to see some positive sides of each of these services, and some room for improvement, shall we call them. So the latest data that I had available to me when I was writing these slides was Q3 from the 21-22 financial year. So in that quarter, across West Yorkshire, there were 2,274 DMS referrals, which is quite positive. Not least when you look at the ranking, and at that point we were getting the 2nd highest number of referrals in England, so really good. And that graphic on the right there is one from the PSNC clinical services statistics, which I believe you as contractors should be able to access and actually look at how your own pharmacy is performing compared to others as well, if you wish to. So we know from the data that 98% of West Yorkshire pharmacies have received at least 1 DMS referral since the service started in February of last year. And that ranges, as you can see, the ranges are there. One of the newly emerging statistics is that for every 23 DMS referrals that are made to community pharmacy, that saves 1 unplanned 30-day readmission. So across the whole of, since we've started DMS since last February, in theory, that means we've saved 522 unplanned 30-day readmissions across the ICS, which is a sizable number, and in terms of total healthcare statistics and costs to the taxpayer, that is a good saving. So you are having a positive impact on patients who are getting this service. However, 27% of referrals remain uncompleted. So I've got a little bit of a scenario here for you. So in February of this year, across the ICS, there were just over 1,200 referrals. We know that 518 of those referrals, a full claim was made. So all 3 stages were completed for those 518 referrals. 79 referrals, only stage 1 was completed. We don't know why, because we don't have access to that level of data. 75 referrals, only stage 1 and 2 were completed. And in one instance, 1 and 3 was completed. So if you look at that in terms of loss of income, so the one pharmacy that only did stage 1 and 3 was a loss of income of £11. So you might say, so what? However, those pharmacies that only did the stage 1, that was a potential loss of income of just short of £2,000 in 1 month. So not a sizable, not an insignificant number. What we are seeing when we're comparing the data is that when we look at farm outcomes data in terms of the referrals that have completed and compare that with the claims that the Business Service Authority are saying are being made, they're very disparate. And so I thought it worth highlighting, if you didn't know already, that when you press save on your DMS referrals and you've said you've completed them, that doesn't make a claim. At the moment, you do need to go into MYS manually and add those referrals to make a claim. So if you hadn't realised that, you might have a lot of catching up to do, and that might be why you're potentially not seeing the income from DMS that you anticipated you might see once the referrals started coming in. And looking at the data for the whole of England, I think a lot of pharmacies will be in that position. So a few tips here about how to make it happen better. Have you got a process in place to check farm outcomes, an NHS mail? I've already mentioned this, but referrals don't necessarily just have to come from West Yorkshire, they can come from anywhere in England. So don't just assume it's from your local trust. Ensure the whole team is trained so that they know what they're doing with those referrals when they come in. There is a virtual outcomes training package, which we've made available free to all contractors in the across Convenience Pharmacy West Yorkshire footprint. And I'll talk about this a little bit more, and I've alluded to it right at the beginning, but these patients are most likely to be eligible for other services besides DMS. So don't just see them as a DMS referral, see them as what other services they are as well. And have you got a process in place to track the patient? So you might have had that initial conversation with them, but can you track where they are, and are you therefore able to either complete all 3 stages yourself, or if you can't, but you know where the patient's now gone to, that you can pass it on to another pharmacy, so that that patient remains safe from their medicines, which is the whole point of the DMS service. So moving on to NMS, I'd forgotten some of this because it's a long time since I looked at the drug tariff, but this slide here sets out the different payments depending on whether you've reached certain targets within the NMS targets that everyone can achieve if they wish to. So minimum payment £20 for NMS, maximum payments £28 per NMS. Might seem quite small difference when you talk about one NMS, but add that up over the course of the year, and that will be a significant difference. So again, just looking at some data, so there was just under 31,000 NMSs taken place over West Yorkshire, again in Q3, slightly under 30,000 if you exclude the distance selling pharmacies. The actual claims that were made for NMSs came to just under £794,000, an income to an average of about 443 contractors. So that's about 2/3 of our contractors. So that's equaling just under £1,800 per contractor per quarter. Again, in Q3, the footprint across Convenience Pharmacy West Yorkshire was the second highest. They had the second highest NMS interventions in England, and 53% of pharmacies in West Yorkshire are consistently providing NMS. And the key really is to provide it consistently where you can. It's like anything else. If you don't use the knowledge and the skills that are associated with the service, you start to lose the competency to deliver it. So looking at where we can improve, so the PSNC clinical services statistics ranks each LPC against each other and against a national average. So in Q3, although we had lots of NMSs, in terms of the NMS per item, we were 17% less than the national average in Q3. And at that point, 5.5% of our contractors had never claimed an NMS. So that's about 29 contractors. But if each of those contractors did one NMS a day, and I've based these figures on You might not want to do it at the weekends because you might be too busy, or you might not open at the weekend. So I've based it on a 261-day year. So if you did one a day for 261 days, and only got the lowest payment band for it, then that's a potential loss to West Yorkshire as a whole of just over £151,000. So that's not an insignificant figure that's being lost to contractors in this area. So most of the figures that I've put in the slide deck here about NMS relate to a pharmacy who dispenses an average of 7,000 items per month. Any items above, any NMS is above 7 a month, attracts payment of £25, etc., etc. And then once you get to 40%, it's a cap. However, if you're dispensing an average number of prescriptions, but at that £28 fee level and doing effectively one a day, that's an additional income across the footprint. Additional income to contractors of £784 a month. So again, not an insignificant figure. And if every pharmacy in West Yorkshire achieved 90%, accepting that that's very difficult to do at the moment, that could be an extra £940,000 across the footprint of Community Pharmacy West Yorkshire. So we are missing out as a sector in West Yorkshire on a sizable income in terms of what could be achieved with NMS. The real key is getting prescribers on board to ensure that any patient prescribed an eligible medicines refers for an NMS. We're working really hard to make sure that that happens, but it will be really helpful if you get the opportunity to have either those conversations with your local practices, your PCN clinical director, whatever that looks like. But there's several little projects that I've got on the go that will hopefully result in more prescribers referring patients for NMSs. So hopefully that will help in the long term. Ruth.
Alison, is it okay if we pause for a few questions? There's been a few pop in chat. I know,
of course, yeah.
It's really hard for you to do everything. So shall I ask the question? And I've actually been putting some answers in PS&C, but I'll start off with the questions and then we can go from there. So
right, yeah.
We've had a question, how do you claim for DMS, which I think you probably covered. But do you want to just reiterate how you claim for DMS?
Yeah, DMS, you need to log on to the NYS portal of the BSA and transcribe your completed referrals into that portal.
Thanks, Alison. Another question related to claiming, can we claim all 3 stages at the same time?
Not 100% certain, but I think you can.
Fine. I wasn't either, Alison, but I put a way to check PS&C's website, and I've put the link to their website DMS pages in the chat. So claims should be made once the service has been fully completed. So you need to wait until you've finished the service before you make it, or if indeed, as Alison pointed out, you've done a partially completed DMS because you can only do certain stages, then once you can't complete any further stages, that's when you claim. So you do actually claim all 3 at once rather than doing it as you go along.
Yeah, curious.
You're welcome. Another question, it's from Jay. We get DMS for many MDS patients. I sometimes struggle to complete stage 3. Any tips?
So stage 3 is the conversation with patient and or carer. Yeah. So I guess MDS patients can be more difficult than those not using compliance aids because they're more likely to be patients who are housebound. I believe there's a remit within the service spec, but again, we might need to double check that you could go to someone's house and have that conversation with them if you wanted to. That obviously causes other knock-on problems, but I'm fairly confident that the service spec does allow for that.
Yeah, and you can do it by telephone or video consultation, couldn't you, Alison? So the option is that you can do it remotely, and don't forget you can also do it with the carer as well. And I've checked and put the question and answer for that from PS&C. So ideally it should be the patient, but if it's the carer in all reality who is managing that medication, you can actually have part 3 with the carer, which I think is a useful thing to know. A couple more questions have come in. So how do you claim the startup fee for DMS? I know the answer to this one if you don't, because
I don't remember off the top of my head, so go ahead.
It was automatic because DMS is an essential service, and so therefore every pharmacy, whether they be bricks and mortar, a distant selling pharmacy, a large multiple or independent, has to provide DMS. So it actually automatically went through to all contractors. So you didn't claim for it, but you all got it. And the other two things are just people saying thank you for answering the questions. So I think unless anybody's got any other questions, I've cleared the chat for the moment, Alison.
Great,
so
thank you.
Over to you. So thank you very much. That's really helpful.
Okay, that's fine. Yeah, just keep flagging if there's more questions coming through. That's fine. So we've done this slide, I believe. Yeah. So moving on to hypertension. There was a setup fee of £440 for each clinic check you do. It's £15, and for each ambulatory monitoring check that you do, it's £45. There are some incentives. I think this is probably the first time we've seen some incentives associated with the service. So year 3 was last year, so we're into year 4 now. But just to use last year as an example, if you provided 5 APM interventions within that financial year, then you could claim an incentive fee of £1,000. If you didn't do it last year, or you didn't start the service last year and you're doing it this year, then you get you need to do 15 ABPM interventions to achieve that same amount. So more work to do for the same amount. But if you keep on doing those, you then get a payment of £400 every year for those 3 years. So not bad incentives to have. The PSNC announced in one of their newsletters, I think it was the back end of last week, that the BSA have now made it possible for you to make daily claims for hypertension. So you can go in and pop your claims on as you've done them. You don't have to wait till the end of the month, which is good news. And we have also heard over the last weekend that Farm Outcomes is making available to contractors a module which eventually will be provider pays, but to begin with will be free if you already utilise their services. And they're also putting in place a GP solution, which we believe will be similar to Farm Prefer, like for CPCS, but we're not 100% certain yet because we haven't seen it. But we know they're both coming on board in August. So that should make communications between pharmacies and GP practices, particularly where the GP practice is making the referral, much easier. So again, some positive facts. Just over 1,700 BP clinic checks were carried out in Q3. And at that point, we had the 4th highest number of clinic checks in England. If we look at more recent data, 63% of our contractors have signed up to deliver the service, which is fantastic news. The number of ABPM checks are increasing. There were 123 of those across West Yorkshire in March. And activity rates are rising. So for quite a long time, people had signed up for the service but hadn't started to deliver it. But that is starting to happen now. So 10% of contractors who signed up were active in January compared to 21% in March. And looking at some of the data that's coming in, I think we'll start to see that activity data rise quite quickly from this point onwards. And 8% of contractors have delivered at least one ABPM check, which is brilliant because obviously they're the patients most at risk from undiagnosed hypertension. However, we were 7% less in terms of BP clinic checks than the national average, and 91% less than the national average for ABPMs. I suspect that's because people were still getting used to the service, still getting used to the right patients to target, and therefore weren't necessarily targeting the patients who needed an ABPM check. But let's wait and see. But those numbers are rising. So when the pilot was conducted, they did a bit of an evaluation that suggested that for every 10 clinic checks that you did, that should lead to one ABPM check. So if you have in your head, do 10 BP checks and it will lead to one ABPM check. And on that basis, that generates, every 10th patient generates a total income of £60, not £15. However, anecdotal data hasn't been evaluated yet, but PSNC tell me that anecdotal data suggests that somewhere between 2 to 5% of clinic checks are leading to ABPM checks since the service was started to be rolled out nationally. But if each pharmacy did 10 clinic checks and one ABPM check a week, that generates £780 a month, which is over 400k per month revenue extra over and above dispensing and any other services into West Yorkshire pharmacies. So again, not an insignificant number. To hopefully spur some of you on, particularly those who might be a bit sceptical about the service or finding it difficult to implement, there are some PCNs, and we were hoping one of them would come and talk to you this evening, but they weren't available, that are starting to look at this with a view to helping you find those patients. So in Beeston PCN in Leeds, the PCN pharmacy technicians were hearing from the community pharmacy contractors that they were finding it difficult to find the right patients for this service. So what those two PCN pharmacy technicians are now doing is they're looking through GP records for patients who are either on antihypertensives with no diagnosis of hypertension, or have had a high blood pressure reading in the past and again aren't on treatment. Ringing those patients, talking to them, explaining to them about the consequences of undiagnosed hypertension, and recommending that they go to their local pharmacy or a pharmacy that's delivering this service to have their blood pressure checked. And the pharmacies, I believe, in that area find that really useful, and are now starting to, the numbers in those pharmacies are starting to ramp up. And the even better news is that the Royal College of General Practitioners not last weekend, the weekend before, published some guidance that's about what GPs should be doing to sort of reset and recover after COVID. But one of those things is to start to make referrals to community pharmacy for blood pressure checks. So hopefully the fact that the RCGP are promoting that service will mean that more GPs will be prepared to sit down and take the time to make those referrals. So moving on to CPCS, any more questions that I need to answer before I move on, Ruth?
Yes, please, that would be great.
Okay, yeah.
Clarify. Now, again, I've tried to put some answers in, but it's better if we hear it from you. Thank you. So for the clinical blood pressure check, do we have to share the results with the patient's GP?
Yes, you do. So even if the results are normal, you have to share them with the GP.
Yeah, I've put a link in the chat to the service spec, and it's in Annex B. How quickly you've got to inform the GP. Somehow it depends on what the result has been, but it outlines it in there. But yeah, it's every single one. And somebody's apologised because we're going back to DMS, but I think it's given that information you gave around the fact that that we have got concerns that we think there's a gap between DMS referrals, people doing it and then claiming it on MYS. So can we backtrack and claim for ones completed? Don't think we have claimed on MYS.
I don't know. I think that's one we'll need to ask the question of the BSA, or at least look on their FAQs on their website and check.
So and I don't know for sure. I think you can, and the reason I say that is if we look at some of the BSA data that came through, some of the claims seem to be quite old. So that's why we're having a problem tallying up the data we see come from our hospitals and the data we see from the BSA. So I think you can. But yeah, I'll see what I can find in the remaining time and get a definite answer. But yeah, I also think
you can, because I think that portal wasn't there for quite a while, just after the service started. So I think there's an expectation that people will be on catch up, but there may not have been an expectation that it was such a big catch up as it might be for some contractors.
Yeah, so yeah, I would recommend that it does take time to put that detail in, but it is worthwhile you doing and giving the payments that are linked to that service. I think, Alison, that's it for the questions for the moment, but please keep them coming, they're really great.
Okay, brilliant, thank you. It's great to see that everyone's engaged. Thank you. So moving on to CPCS. So I'm sure you all know that it's £14 per completed consultation. If you're not quite sure what is a completed consultation, then PSNC have produced a guide. When you get these slides, there's a hyperlink that will take you straight to it. And there's a plethora of resources to use with GP practice when encouraging them to make GP referrals into CPCS, some from PSNC and some from all sorts of different organisations have produced these sorts of resources. So there's no shortage of information there to help you to work with GP practices. So again, looking at the data, in Q3, we were equal with the national average in terms of CPS referrals. December 2021 for us was the best month we've had, with just over 1,100 referrals. Sadly, the direction of travel at the moment is going down rather than up. However, 45% of GP practices are now actively sending referrals, and 36% of contractors have received 3 or more GP CPCS referrals by the end of the last financial year. So broadly speaking, going in the right direction, but there's still a few bumps in the road. There's a significant amount of lost income related to CPCS, and as you'll see from the tables on the right there, it's actually getting larger, not smaller, and that's predominantly because the rates have been dropped and the rates referring back to GPs are rising. So you can see for yourself how that lost income adds up month by month. And in Q3, we were 27% less than the national average for CPCS referrals in proportion to the items dispensed. So some work to do there, both in making sure that GPs are making the referrals and also making sure that as many as possible are completed where they can be. So again, looking at how we make this happen. So again, it's about making sure that you regularly check in, have a process in place, regularly check farm outcomes. So even if you know that your local GP practices are using farm refer for farm outcomes, please also make sure that you check NHS Mail just in case you're getting referrals from somewhere else, because patients are fickle people. They can do that sometimes. And again, ensure the whole team's trained. And again, there's a virtual outcomes training that's free for you and your staff to access. For GP CPCS in particular, it's really key to form strong communication channels and relationships with GP practices. And I think what I've started to reflect on is that strong relationships with your GP practice doesn't necessarily mean strong communication channels. So think about that and think about, have you got them both? If not, which one do you need to strengthen if you can? We've spoken about this previously, but we recommend that if you do need to make a referral back to the GP, that they use the S-bar way of doing that. So that's on the right-hand side. So S is for situation, B for background, A for assessment, and R for recommendation. And that way the GP knows categorically why you're sending that patient back. So always be really clear about any onward referral pathways where you can. So for example, if you're a contractor in Leeds, you'll be aware that we are working with Leeds CCG to very soon put in place an ENT assessment service. There'll be two routes into that. One could be you've had a CPCS referral that's for an ENT condition. You've done what you can in terms of the CPCS, but you're now providing the ENT assessment service. You've been trained how to use an otoscope, look in someone's ear, look at the tympani and see whether it's red and angry and whether you think that the patient potentially needs an antibiotic, and therefore you can refer appropriately for the antibiotic. So we are trying to put other services around CPCS to help you to support that. The service I've just described is at the moment is going to be in Leeds for the initial period. Use tools to help you to help the GPs. I quite like this one pager. Again, you can download it from the PSNC website because it tells them at a glance what conditions are suitable and what conditions are not suitable to be referred to you. So a great aid memoir for the care coordinators who may be making those referrals from their GP practices. Oops, keep losing. Oh, here we go. So I alluded to this at the beginning, patients are very often not one service. So if you get a DMS referral and all you do with them is all 3 stages of the DMS, you're going to earn £35. Not a bad fee, but it's £35. However, if you get a DMS referral and that patient's been started on a new medicine whilst they're in hospital, and you know that because you're the patient's regular pharmacy, then you can also do an NMS intervention. And depending on the volume of NMSs that you're doing compared to your dispensing volume, you can claim somewhere between £20 to £28 for that service. So if you've done all 3 stages of DMS and you've done an NMS, and you luckily one of those pharmacies who are able to claim the £28 fee, then in this instance, that same patient is now worth £63 to you, so nearly double. If it's coming up to September, or is September, between September and March, and the patient that you've got in front of you, particularly if you're having that conversation in the pharmacy, even if you're not, if they're eligible for a flu vaccination, you should be offering that to them if they've not already had it with their GP. I've guesstimated £11 because we don't know what the fee is going to be for this next season. But now you've done a DMS referral, you've done an NMS, you've done a flu vaccination, and the maximum value of that patient is £74. If you're also engaged in locally commissioned services or any other advanced service, I've just used a locally commissioned service as an example here. So again, this would be Leeds, but if that patient has also either had their inhaler changed while they've been in hospital or newly initiated on inhalers whilst they've been in hospital, you could do an inhaler check. £17 if you do both parts of the service. So now when you tot all those up together, that patient's worth £91 to you. So again, over nearly 3 times as much as what the value you would have had if you just only stuck to the DMS because that was the referral in front of you. So just thought that might help sort of concentrate the mind where you're thinking about patients as those referrals. You can start at any point. I just started with DMS because it's an essential service, but as I say, you can start with any service. This is just for illustrative purposes. So, have I got the wrong slide deck here, Ruth? Or yeah. Do you want over to you then, Ruth? Because we're not going to talk about, we said we wouldn't do the smoking cessation in the end.
Do you want to go back a couple of slides? There's a few more questions, Alison, and I'll come on to the summary. Is that okay? So, yeah. That's been really helpful. I haven't answered all the questions in chat because there's been some really great questions, Alison. I've tried to answer those that I can, but shall we take them so that those that can't access chat because maybe they're on a mobile device can hear the answer? So I'm trying to think which one, where we've, as far as we got. Sorry, we talked about blood pressure. Back to DMS, we did that one. Apologies, guys. So a question from Amanda. Is there any guidance on what to do if one of the blood pressure values is high, but the other is okay? For example, if the systolic is over 140, but the diastolic is under 90, do both values have to be over? Very good clinical question, Amanda. I have looked at the service spec and it does actually specify as a kind of over. So I would say use your clinical judgment. It depends how over it is. Maybe you want to repeat that one off blood pressure to see where that person is. The readings can be affected, by things like exercise and stuff like that. So it could be that actually they're within range when somebody's you repeat that blood pressure. So it doesn't say, and I can't find a PSNC question on that. So I think you have to use your clinical judgment. How much over is it? So if the blood pressure was 142 over 80, really that probably indicates that you're probably within that range, but it's around how close to the 90 are they for the diastolic. So yeah, a bit of a woolly answer for me, I'm afraid, because there is no guidance on that. But I think as the person responsible for the service, you have to decide what you think using your judgment, and that's fine. And what you might want to ask your local GPs if you have a conversation with them to say, what would you do if you saw this, and get a bit of guidance from them because they will have seen it a lot more.
So having spoken to quite a few GPs about this service, I think they would prefer that conversation than just getting a referral back for somebody that they then think that then they go, why have you sent me this person back? Because for them, that's, as you say, that's just something that they manage all the time. So I think they'd be really open to sort of what I would call some sharing of knowledge type conversations, as well as just a conversation about the fact that you're delivering this service.
Yeah, thanks, Alison. Do we refer under the threshold BP readings as well? For example, if somebody's got a blood pressure under 120 over 80, so basically they're normotensive. So the answer to that is yes. So if you have a single blood pressure check, you still refer those in, Alison, even if the person's blood pressure is normal, don't you?
So when you say refer, so you have to send all readings back. Yes.
I think that's what the question means, sorry.
Okay, if that's what the question means, then yes, you have to send all, even if it's normal, you have to send those readings back to the GP, yes.
And why is that, Alison? Because the GP is going to get quite a lot of readings. So why is it used in GP practice to know the BP?
So I'm guessing it's because they've also got targets around hypertension. So it's a little bit like the flu thing, where you do the flu jabs and it counts towards their however many they need to achieve for their targets as well. Hypertension is a key outcome from the long-term plan for this year, hence the reason why the world and his wife have been encouraged to take people's blood pressure at the moment.
Yeah. I think, yeah, it's about making sure that record's there, isn't it? And they can look at who's at risk and who maybe is less at risk. Question from Daniel, and I'm happy to take this one if you want, Alison. Is there any way we can influence the ear, nose and throat service to include all pharmacies? Would it be helpful if I gave an update on what we actually did from West Yorkshire? So we became aware that there's several other areas have got not necessarily ear, nose and throat, but some kind of iteration of some PGD or extended kind of CPCS service. So we put a bid in actually to cover the whole of West Yorkshire. And we asked as a West Yorkshire lump sum, but we also went to each of the CCGs and said, look, here's the outcomes, here's the patients who we can help free up from having to go to the GP practice, and we number crunched all the figures for them, showing them how many GP practice appointments we could save, how many hospital A&E presentations we could save. So that went everywhere. Unfortunately, the only place we managed to secure that funding was in Leeds. Sadly, it isn't recurrent funding, so we know there's a slight risk to that service that if we don't get recurrent funding, when the money's gone, the money's gone. But as with all these things, we will, look at the feedback from the service. We will look at the outcomes we can demonstrate for patients and for the system, and we will use that to try and champion, to try and spread that service so that it becomes open to more pharmacies across a better spread. So, it's just where we get lucky, and it does feel a bit lucky from sometimes as to where we can get that money from. So we will continue to champion, Daniel, because we think CPCS Plus is a really good way of kind of enhancing the clinical role we play. Rochelle has a question. What is the best way to refer a patient back to the GP if required during a GP CPCS consultation?
I guess it depends on the urgency. I think most people are using NHS Mail, as far as I can make out. But if you've got a patient in front of you who, is clearly a lot more poorly than they might have, been perceived to be when they spoke to a care navigator on the telephone, then clearly the better route might be to pick up the telephone and speak to somebody in the practice. So yeah, I think it depends on how ill the patient is or isn't.
Yeah, again, it's your clinical judgment, isn't it? How urgent does that person need to be seen? And for some people, it may be less urgent than others. And it's about talking to your GP practice as well as the routine. So we do know for urgent CPCS, you should have, for most practices, you can have that healthcare professional line, so you can actually avoid joining the patient queue. Not available for all practices, but for many. You should find that on the NHS Service Finder, which is a really good way of kind of finding that number so that you don't have that undue delay if you need to refer somebody in urgently, so that you're not delayed in doing so.
And I think there's something I've just remembered now from what we did, the hypertension service, CPCS service particularly. I believe there's something on the PSNC website that says if you've had conversations with your GP practices and they want you to refer to an urgent treatment centre, for example, and then you can, as long as you've got those local plans in place, and you can do that as well.
Thanks, Alison, that's really helpful. One from Daniel, and I'm not sure I understand it, so we might need Daniel to clarify. Has anyone had issues with being located on farm outcomes from the hospitals? So I don't know if that's related to the fact you think the hospitals aren't referring to you. So we know that the number of DMS referrals are quite low, don't we, Alison, really?
They are, they seem to be dropping at the moment, but we don't know why.
We are working with hospital trusts to try to increase that and actually extend it so that they aren't just using it for their multiple compliance aids as well. So we're trying to kind of get that volume increase. So it's around patient choice, and the hospitals will look at nominated pharmacies, and on the whole they will refer to the nominated pharmacy. So I don't think it's necessarily an issue. It just could be the volume of DMS means you don't see them very often. I think that's hopefully the issue. Question J. So if somebody's blood pressure is 142 and you say come back next week for a retest, can you claim twice? It doesn't explicitly say you can in the service spec, but it doesn't say you can't, because there is that clause that we've got patients we've got to target, the BP check too. But from my interpretation, it says that if you think there's a clinical need to test somebody else, you can do that outside of the service spec. And so I think you could justify it that way. So if anybody came to question, why did you do it twice? As long as you've got a record to demonstrate why you did it and there's a clinical reason, I can't see there being an issue. Would you agree, Alison?
I agree. I think having a contemporaneous record around that intervention is the key thing for all sorts of reasons.
Yeah. Question for Amanda. Is the specific guidance about creating a DMS report on farm outcomes mentioned on the PS&C briefing? For anyone who hasn't claimed for DMS, they will need to know how to create that report to transfer the data to MYS. So I think, Amanda, this relates to the fact we had this conversation, didn't we, a while back, that how do you create that report? Because although you're seeing your DMS on farm outcomes and putting details in, you have to also make a separate claim onto MYS. There is a way of doing that, and I believe, and I will just go away and check in a moment, it's on our website to do
if it isn't, so apologies, Amanda, because Lisa did actually send me copies of the tweet that you did on this, and I meant to put them as a graphic on the slide and I forgot. I'm really sorry. So we have got that information if you can't find it on PSNC website.
I know how to do it, but I just wanted to make sure, because it's not, as far as I can see, it's not on the PSNC briefing anywhere. So
we can as I say, I've got copies of whatever you put onto it, so we can with your permission we can share that with people.
Yeah.
We have on our website, if you go to our website, Pharmacy Contracts and Services, and then onto DMS, we've got a Farm Outcomes DMS reporting to MIS guide, and I will just quickly pop that into the chat so that you people that are here have got the quick shortcut. But if you forget where it is on our website as well.
Thanks, Rue.
You're welcome.
Is that them all?
I think that's the end of the questions. Thank you for the moment.
Okay, so we will flick to the last slide now then, which you were going to talk to.
Yeah, first I will say a massive thank you, Alison. That was really, really helpful and quite in depth. And I know you, Suki and Lisa from the services team have kind of really crunched that data to kind of get that. So thank you. That's, been a lot of work, but been really helpful. So I thought it'd just be helpful just to summarize some of, when Alison shared the slides with me, what, some of my take-home messages were. And for me, I think farm outcomes or MYS really, think of it as your cash register. So do make sure that you, all referrals and all service opportunities are completed and claimed, because, there isn't a lot of give in community pharmacy. Our funding has been flat for nearly 8 years now. So we need to make sure we don't miss money that we shouldn't own. We wouldn't not put something, charge somebody for a service we provide us with a till. We need to make sure actually we think the same about MYS and where it's linked farm outcomes. So some of my take-home messages were there 250,000 up to £250,000 in DMS over a year. We think is being missed, where we can see the data that comes in to us from the hospital. So we know the number of DMSs that the hospitals are telling us they're making, and we can see those referrals go through farm outcomes, so we know they're happening. And if we compare that to the BSA data, that's a sum of money we think is being lost. That's over the year, nearly £500 on average per community pharmacy. That's a lot of money not to have. So please do ensure you are claiming your DMS via MYS, so that you're not one of the pharmacies that's having this big differential between referral, doing the work, but not actually then getting the funding for it. Going to NMS, if all our pharmacists across West Yorkshire did one a day, and Alison said, taking out weekends and stuff, because we know that that's not always possible, but actually look at the amount of money in a year that we could actually have coming into West Yorkshire. That's a massive amount of money. So, £1.8 million. That if we put it down to each pharmacy, if you did one NMS a day, that would, depending on, as Alison pointed out, where you are in the tariff for the volume you do, but that could bring between £5,000 and £7,000 into your pharmacy. And if you did 3 a day, that would be at least £15,000. So that's a lot of money for NMS. And one of the great things about NMS is We don't rely on other people to make referrals. This is within our gift to make sure we offer NMSs. And I know the pharmacies that are really successful in doing NMSs, you know, they have the conversation with all their patients, they get the consent, they actually keep often Excel spreadsheets to track, making sure that they've done the different stages of NMS of each of their patients. So they're on it, but actually their work is delivering them income. From the hypertension service point of view, you know, if your pharmacy did 10 clinic checks a week and 1 ambulatory check a week, you know, that would generate over the year nearly £10,000. Again, it's you know, not an insignificant amount of money. And if we look at the lost CPCS income, you know, this is where we think, that goes to the chart Alison put on that table, where we can see that there seems to be an awful lot of loss to follow up. And we see that happening nationally, but I think we don't always compare well. Now, not every CPCS is going to be able to be completed, but we believe that some are being closed when actually they could be completed. That's a lot of money too, and you know, it's not huge per pharmacy, but it's still £86. You wouldn't you know, you would be gutted if you lost something worth £86 from your retail part of the pharmacy. So you know, it should be no different from the clinical side. So for me, there's an awful lot of funding there, which you know, we want you to make sure you as contractors you know, are claiming for what you are due, claim for that work. And although we've been talking about the nationally advanced services, we actually have seen in the past through our locally commissioned services like substance misuse and EHC that people aren't always claiming. Now with those services, often they've got a much more defined claim period. You cannot start submitting things months ago. And you know, if you do the work and don't get the money for it, it just seems like a missed opportunity. Yes, Alison.
I was going to say, just going back to DMS. So what I meant to say when I was doing the main part of the presentation is that, as I'm sure all contractors are aware, the hospitals are have what's called a sequin, so an incentive payment for them. I believe that those sequin payments are being based on the claims that contractors are making. So whatever, it's not a problem for pharmacy contractors that the hospitals might not get their money. If you think about it in terms of a whole health economy, if you don't put all your claims through appropriately, then the hospitals lose out on their money as well. So again, that's less money into the health economy in West Yorkshire. So that's just something else to bear in mind.
Thank you. Yeah. And I've had a very money orientated conversation. I don't think we should shy away from that. The reason we're able to provide healthcare is because we get paid, and that's the same for any other healthcare provider. So we shouldn't shy away from that. But what we must also remember is all these services we've talked about provide a clinical benefit to our patients. It helps them understand their medicines more. It checks that they haven't got undiagnosed hypertension. It supports them following discharge. And we know that actually people often take a while to readjust to looking after themselves again. So all these services have got really good evidence base around the positive impact they have on our patients. So not only are you getting a better funding stream, hopefully by doing these services, you're actually making a really big difference. And I want to say thank you to you all, because you all make such a massive difference to your patients every single day. Not everything we do is funded, I understand that, but some things are. So yeah. So I think that was it for the summary. I thought it'd be really helpful, given we've got 10 minutes, from a next steps point of view. So if anybody got any questions, please shout up and please ask them. I'd be interested to know though, and if people could put it into the chat, what is your, what's been your take-home message from tonight's presentation? What key message are you going to kind of go away with? So I'm going to give it a couple of minutes to put that into the chat. I'm just interested to know what people kind of find the most useful or shocked you the most. So one of the comments is thinking more about linking services together. So that, that really great diagram you put on, Alison, a patient, you think about what else you can add on. It's about giving the best clinical input to that patient where relevant. So that's helpful. Claiming DMS, where pharmacies maybe haven't done that before, or they've done the work and they haven't been sure of how to claim. And as we say, we're relatively confident that you can put them on and backdate them, and we'll get them done sooner rather than later. But that could be a really good recompense to a bit of money coming in on your statement for work you've already done. So that's another really good one.
So we do know that the farm outcomes are trying to work with the BSA, so that eventually when you press complete, it will then ping to NYS, but that API is not in place yet.
Yeah. Somebody's, but we don't get many referrals for CPCS, so they're going to take away an action to engage with practices and discuss what we offer, and also discuss some referrals guidance. That's great, and I think actually, given that having a local conversation gives them the confidence, the general practice, that you know what you're doing, you've got the referral pathways in, you're going to safety net those patients that you see. And for me, some of the key messages that we use talking to practices is, we know from some of the pilots that once it gets settled in, an average practice can refer 55 patients a week to CPCS. That's 55 appointments that can be given to patients with higher acuity conditions. And we also know that actually the referral rate back into the practice, once it's settled down, is about 1 in 10. So for every 10 referrals that make, yes, I'll get 1 person back. That's clinically appropriate, but we'll manage 9 people in community pharmacy. So some really good messaging there. And I'd suggest you'll have a look at our website, because we've got some links. There is a lot, and that's an underestimation, a lot of support going in to getting GP CPCS routinely used within every single GP practice. And in fact, one of the NHS planning guidance talks about universal CPCS. So that sounds to me they've really put the cards on the table. And there's NHC and I support GP practices, and there's different things to help support them get their heads around it. So please have a look at the CPCS pages on our website, and we've got local information on there which you can signpost your GP to. There's things like I don't know what it's called now, a kind of a toolkit for GPs to implement CPCS, and you can download that and share that with them, so that all the work's been done. It's just about having the conversation and linking them to the resources. Next one, I have been claiming all services, but I feel training the staff is also important, especially with the NMS, as I might have missed a few NMSs. I think that's a really good point. It's many of the services, and it's often for that reasons, have to be done by the pharmacist. So that does really tie up the pharmacist clinical time. But if you're going to make a success, it is about getting your whole team engaged, and they've all got a role to play. So for NMS, you're absolutely right. It's about them identifying every person that could have an NMS, having that conversation, getting that consent. That can all be done by non-pharmacists in the pharmacy, and that's where we see it works well. That's some really good feedback. Thanks, guys. Really helpful. I can't see any other questions. So, Alison, I think it's back over to you to say your thanks. Oh, I've got somebody just put one in. So,
yeah. Sometimes private services generate better revenue than NHS, and so important to get the right balance. Yeah, agree with that. Yeah.
Yeah, and that it's about you understanding your population and what is going to be a good valued service and what they'll be prepared to pay for. So yeah. So Alison, I think that is at the end of the question. So over to you.
Yeah, so thank you everybody for taking the time to come and listen to what we've had to say this evening. We have included the questions, so we will make sure that recording is uploaded onto the website along with a copy of the slides, so that you can look at them later, click on some of the links that are in there. If we have got any unanswered questions, or you think of questions after we've finished this evening, please do feel free to email me at alison@cpwy.org, and I'll do my level best to answer them for you. And if I can't answer them, I'm sure somebody will be able to, even if it's not in CPWY, we will find the answer for you from somewhere. But thank you for your time. We appreciate how busy you're working during the day, and how hard it is to then come on and put another hour so at the end of the day. So really grateful that you turned up this evening. Thank you.